So a very good afternoon, everybody. I'm so happy to welcome all of you. I think we're gonna have a very great afternoon because it's a brilliant project that we've been working on for the last 2 years, and of course you wouldn't be in this session if you weren't interested. But again, we want to have, let's say, bariatric surgery on a next level within Europe and outside Europe as well, of course. And that is why 2 years ago we started with a project in which the IFSO, let's say, collaborated with the UEMS, the recognized, let's say, European Commission that provides us with good ways of educating, and certified exams. And of course, if you want to undergo the exam, let's say the 6th of May in Malaga this year, then of course you would like to know what is in it. So, besides the people that have already registered, I do advise you to go to either the IFSO website or the UEMS website to, let's say, register yourself. We are looking for the next generation of leaders in bariatric surgery that want to show everybody that they have a certain knowledge level up to standard for nowadays, so that we can lead you to, let's say, becoming that future leader. What we prepare today for you is a sort of overview of what we are going to do during the exams. We're going to introduce the whole committee to you, of course. That is up to the first speaker, Daniel Garrow. But most of all, we want to show you that it is, yes, a lot of work, but on the other hand, it is doable. So first of all, I would like to introduce Daniel Garrow, who's here in the audience. He's gonna, let's say, do this session live. It's a two-way system or two-part system in which he will show you, let's say, the ins and outs of one part. So there's three parts to an exam, one part which are clinical cases. He will guide you through it, and we are going to show you one case that might be or was used, let's say, last year during the exams. So Daniel, the floor is all yours.
Yeah, thank you very much for this kind introduction, Edo. I would like to welcome everyone to today's webinar. So we're going to talk about what to expect at the exam, and my duty was to bring a clinical case. My name is Daniel Garrow. I'm a consultant bariatric surgeon at the University Hospital Zurich, and I'm also active within the Young IFSO. So what can we expect? First of all, one can expect to meet us. This is the current team of the IFSO EC UEMS committee. Members are Edo Arts, Dieter Birk, Daniel Garrow, Thibaut Cost, Romano Schneider. You will hear talks from most of us today, and you can find more information about the team and the administration online. Feel free to reach us anytime if you have any questions. So regarding the oral exam, the ultimate goal of this exam is to test the candidate's ability to lead a bariatric service safely. So how do we do that? What are the key aspects? The exam is structured in about 45-minute framework. This is a live session where you will see two examiners, and you will have to solve 2 or 3 cases based on real or hypothetical scenarios, including acute care surgery, emergency surgery, complications, and even elective topics within the framework of metabolic bariatric surgery. How do we assess the people during the exam? So examiners will focus on clinical judgment, efficiency, patient safety, and adherence to evidence-based standards. Our approach is the following. Candidates must verbalize a structured approach: history, physical exam, differential diagnosis, diagnostic studies, and treatment options. These can be non-operative and operative treatment options. And we will be also interested to hear some information on the background of diseases, potential complications, classifications, prognostic factors, and outcomes. We recommend you to use some textbooks, for example, the ASMBS textbook, the SAGES Bariatric Manual, or a collection of published guidelines by the IFSO or other societies. We also encourage you to do mock exams with your peers, use online resources, and as I said, recent guidelines. We can give some tips and tricks, something we like to see during the exam. So we like to see when your answer is structured, it's consistent, there is a logical flow for every case you have to solve, and you cover critically several points. We also encourage you to think out loud and clearly explain your reasoning to the examiners. You will need to be fast. You have to do rapid decision making almost in real time, because you will have not more than 20 minutes per case. So we need quick, accurate decisions, like a discussion in a morning meeting in a real clinical department. We want you to be patient-centered, focus on safety and effective management, including addressing coexisting medical conditions, rehabilitation, and also treatment of potential complications. Based on last year's experience, I would like to emphasize that we expect you to think beyond surgery. You are mostly all surgeons, so we know that you like to talk about staplers and stitches and techniques and devices, but we want to hear during this exam some background knowledge on medical conditions, treatments, some severity scores, diagnostics, a bit more medical thinking than surgical is also welcome. And as I said, do some mock exams with your colleagues, your friends, to improve fluency, confidence, and to keep the focus. After this introduction and overview, I would like to show how it goes in based on a real scenario. So I would like to invite you to Venice. This was the first UEMS oral exam, which took place last year, and I would like to show one of the cases we had there. And I would like to also kindly ask Edo to be my partner, to act as the candidate, and I will act as the examiner. So Edo, are you ready?
I am ready, Daniel. Thank you so much. So I'm shivering at your table. Let's say you're in front of me together with one of the other examiners. You might choose which one, of course. So let's go for the first case.
Okay, so here it goes. This is based on a real world case. Consists a 39-year-old male who had a grade 3 obesity with a BMI 48.6, with comorbidities, sleep apnea, and steatohepatitis. He underwent sleeve gastrectomy in another hospital and was discharged quite quickly without any complications. You work in a referral bariatric center, and this patient presents at your emergency department 6 weeks after this surgery performed elsewhere with sudden onset of abdominal pain. And what would you do?
First of all, I would like to hear out what the actual true complaints are. So is abdominal pain the only issue that the patient has, or does the patient also experience other things like increased pulse or sweating or whatever?
No, everything else is normal. Just a new onset of abdominal pain, which was not present in the earlier preoperative phase.
And what that pain is now going on for a day, 2 days, 3 days?
Yeah, a couple of days, and it's quite debilitating.
Right. Okay. And this patient is now at the emergency department, you said. Okay. Yeah. Well, first of all, I would of course start with some traditional abdominal blood withdrawals or blood measurements. A sleeve, well, that's 6 weeks after, not really a normal, let's say, onset of complaints, to be quite honest. It's quite late in a series. Well, it's a sleeve. Perhaps does the patient know, or do we know anything about oral intake in terms of the amount of fluids taken in the last days to weeks?
Yeah, there was no issue with that.
Okay. And was there anything additional given in terms of medication?
Yeah, just the usual multivitamins, PPIs, and 3 weeks of thrombosis prophylaxis.
Okay. And the thrombosis prophylaxis was based upon the weight of 170 kilos. So depending on what was given.
Yeah, this you don't know, because
we don't know.
operation was done elsewhere, and you don't have access to this.
So can we have blood levels or blood measurements, or?
Oh yeah.
Or do you...
So let's go for it. So we do.
Okay.
These are the lab tests. It's a CRP of 160.
Oh, that's strange.
Whites are normal, and you were about to mention that we also do a CT.
Yeah. Of course, that was the
Uh,
next step. But normally, I first take labs and then only do
yeah. So earlier this morning, I was able to display the video of the CT. For some
ah,
technical
cool.
reasons on this computer, it's not working. So I will show you some key images.
Okay.
Sorry, I was.
But what is surprising after those
Yeah.
many, just going back to the labs, is of course a CRP of 160. That's strange. That is not normal. And white blood cells of 7.5 is normal. So
Yeah.
let's look at the
Yeah, that's a
CT.
mismatch. Exactly. So these are key images of the CT, which during the exam we will make 100% sure that all these videos work to perfection. But these are the key images which should allow you to already make the diagnosis.
Right. So I'm trying. So as a examinee, I try to tell you what I see. Going first to, let's say, the left picture, I see of course going from up to down the heart, part of the liver. I see part of the pancreas, I think.
Correct.
A lot of the let's say vessels of the small intestine, perhaps sort of the spleen on the left there, and it's a little bit. Um, Mushy. Can I use that word? So the mesenteric part, it's a little bit more grayish than I would
Yeah,
expect.
mushy. Yeah, maybe fat straining would be the more
Fat
appropriate.
training, yeah. Okay. Do not really see anything strange in the, let's say, abdominal wall or anything that I can see now because I don't have any working space. The only thing is that the darker spots perhaps in the liver that I'm not used to normally seeing. But fat straining, yeah, that would mean that there's a sort of off flow issue with, let's say, the veins of the mesenteric part of the small intestine.
Correct. And if you look in this area behind the
Right.
under the
The
pancreas,
portal
you
vein.
might find the diagnosis.
Yeah. So yeah, that's the only thing I can actually see. It's a sort of thrombosis idea or
Exactly.
something.
So, sorry?
Yeah, that's what I meant. So you already went to the case, but I said a sort of, yeah, venous thrombosis, but
Yeah,
portal
exactly. So
mesenteric.
it's a portomesenteric venous thrombosis after sleep gastrectomy.
Okay.
So how would you treat that?
Wow. Well, first of all, to be quite honest, I'm not an endocrinologist. So in my case, I would always ask somebody who knows more about this than I do. We're 6 weeks after surgery, so in general, I don't expect if it, so. I want to give something to, let's say, release the or let the thrombosis vanish. Let's say either with something that makes something anti-clotting material, let's say. So probably via IV treatment. If so, liver function, etc., is normal. There's no other.
No other issues.
We have time, let's say.
Mhm.
Okay, so there's no active approach of having to do that. So I would give IV treatment with some sort of anticoagulant, but together
Okay.
with a good endocrinologist or hematologist that you have available in your hospital.
Okay. Anything else?
Um, Anything else? Yeah, that's a good question. No, for now, I would start doing that.
Okay. So let me just display. So basically, you have four things to take into consideration. So what you said, conservative anticoagulation therapy, this is the backbone of the treatment. What you need to evaluate with your interventional radiologist, whether you can do or is it necessary to proceed to a catheter-directed thrombolysis. Here, the access might be tricky to access the portal vein, either transjugular or transhepatic, and you can consider to do a thrombectomy. And as a intestinal surgeon, it's also important to consider whether you need to do an emergency operation in case of suspected bowel necrosis. As this patient was not febrile, had no peritonitis on examination, on CT, there was no sign of pneumatosis whatsoever. Was not necessary. But in the UEMS exam, it would be nice to just list these different treatment approaches: conservative, interventional, and surgical. Okay. Yeah, you can also mention what happens if you don't do anything. So intestinal ischemia is the big danger, necrosis, phlebitis, yeah, and death. So the duration of the anticoagulation would be also an interesting question. At least 3 months, but can be 6 months. It's also not wrong. And at that time, it is recommended to repeat the imaging study to decide whether he needs lifelong therapy or other problems. Okay, so now we spoke about the immediate treatment. What would you do as additional workup? Maybe not during this hospitalization, but as an ambulatory additional workup upon discharge.
Well, first of all, I would consider looking for anything that led to this issue. So first of all, you want to know the why, I would say. So look into intake, let's say, either factors that might have influenced getting this, because to be quite honest, this is, of course, not something really common, Daniel. It is not one in 10 patients that get this.
Yeah, that's good you mentioned. What's the incidence of portomesenteric venous thrombosis after sleeve gastrectomy?
In my clinical hands, let's say,
In the literature.
in the literature, I've never seen one, so that's very good to, perhaps to know, and perhaps there have been, but I would guess around 1 in 1,000.
Yeah, somewhere there. Maybe
Yeah.
it's also underreported. Probably
Right.
it's
Probably, yeah.
underdiagnosed, but
Yeah.
it's yeah less than 1%. That's for sure.
So additional workup, of course, that patient is will be admitted to the hospital for, let's say, any sort of intervention that we just spoke about,
Mhm.
Daniel. And one of the things that is, of course, that still might happen is indeed too little flow, let's say, to the colon. So you have to be careful, let's say, to not miss that in the near future if you don't know how long this has been going on. What you've seen on the CT is that at least the arterial part of the colon seemed at a certain point quite okay-ish at this point, but you don't know anything about the flow towards, let's say, the liver.
Mhm.
So in first instance, is admit that patient to the hospital, take a close look, and of course do blood work. Let's say I would guess, depending on clinical signs and symptoms, at least once every 2 days, and make sure that you don't miss, let's say, certain issues afterwards. Perhaps you want to make sure that the treatment is doing what it should. So after a couple of days, you might repeat, let's say, the CT scan.
Yeah, that's correct. But in this case, everything went smooth. Patient remained asymptomatic or oligosymptomatic. Pain was under control. He could be discharged. So what additional workup would you consider?
Hmm. So you meant actually after discharge. Okay.
Yes.
Very good. Well, I couldn't think of anything else than what I've already mentioned, let's say.
Okay.
So,
Okay.
so of course because
So you
everything is
you will
already
want to
mentioned, so
do.
it's a long time. So yes, indeed. So, oh, you meant all the workup for
Exactly. I mean,
after
you, you
6 months.
you you started very nicely your answer. You mentioned you want to know why this happened. So this
Right.
is called the
Okay.
thrombophilia workup.
Mm-hmm.
Usually you have to involve a hematologist, and they
Mm-hmm.
have a panel. As a surgeon, of course, you don't need to know all of these elements of the panel, but it's always a bonus if you can list 2 or 3: protein C, protein S deficiency, factor Leiden mutation, rheumatoid factor, or things like that. So you need to look for this potential causes. And a very important thing to do is, if the patient is smoking, you have to include him or her into a smoking cessation program. This is one of the biggest risk factor for this disease after bariatric surgery. All right, so the case goes on. How would you assess the risk of post-bariatric thromboembolism? And now we are moving away from this case and we go
Right.
more into general on the topic of thromboembolism. What do you do in your clinical practice? What is good practice to do for elective bariatric patients as a risk assessment?
Right. So in general, I would make sure your let's say protocol in the hospital is a sort of idiot proof. So at least make sure that the whole department works the same. So I've myself worked in many hospitals, and depending on the hospital, there was a sort of different protocol. So the assessment tools is making sure that during the workup for a bariatric procedure, you at least inventory what risk factors there additionally are to somebody who didn't have any prior history. Might be something that you have to take into account. So, for example, what you already mentioned, Daniel, is smoking. That might, for a number of reasons, be an additional thing to work on during follow-up. But most important, have a let's say standardized protocol on how to prevent it.
Yeah,
So
perfect. So
I would say, yeah, go ahead.
yeah, there is a validated tool, the so-called modified Caprini risk assessment tool for the assessment of venous thromboembolic risk. The risk of venous thromboembolism, not just portomesenteric, but all
Yep.
types of thromboembolism, is between 0.3 and 3% after metabolic bariatric surgery. And in this Caprini score, there are all the potential factors included and stratified. Minor are given 1-2 points, and the very severe factors 3 to 5 points. And at the end, you come up with a score between 1 and 5. 5 meaning very high risk, 3, 4 moderate risk, 1 to low risk, and 0 very low risk. So if during the exam, I mean, we don't expect that you list this 100 item of the Caprini score, but if you have some kind of structure, can talk about risk stratification, then you will make the examiners very happy, and it looks really good. Okay. So now we would like to talk about the pathophysiology of portomesenteric venous thrombosis after sleeve gastrectomy. It has been found that it's more frequently occurring after sleeve gastrectomy in comparison to bypass procedures or gastric banding. Could you comment on that?
Yes, of course, I can. Again, I do not have that much experience with portovenous thrombosis, and I'm not a sleeve surgeon. But of course, what I would suggest that with cutting away, let's say that part of the stomach, of course, there might be additional pressure to certain venous structures, but I think most important might be reduced intake of fluids. Because after sleeve, that is in my opinion much harder than after Roux-en-Y gastric bypass.
That's an interesting point. So, I mean, the short answer, nobody really knows. There are potential causes, and there's a nice paper published by the Journal of the American College of Surgeons a couple of years ago, and they named 4 potential causes. So the first one is more related to the sleeve itself. It can be related to splenic ischemia from ligation of the short gastric vessels, endothelial damage from thermal effect on the left gastroepiploic vessel during skeletization of the greater curvature. This is also a step which does not exist in bypass surgery. Whereas the third step, it's the same also for bypass. It's related to the liver retractor. It creates a hepatosplenic congestion if it is put up for a long period of time. Although there are liver retractors also used in hiatal hernia surgery and a lot of other procedures, and the risk of thrombosis is not so extremely elevated. But these are potential answers on the top of this underlying potential coagulopathies and smoking and the classic virtuous triad that we already mentioned.
Yes.
Okay, so next question. Which kind of perioperative thromboprophylaxis can you recommend for bariatric patients?
Well, there's a long list. Making sure that preoperative they are not dehydrated, let's say, and do the right workup, of course, to make sure that you don't miss out on patients that have a higher risk. Second, you could use even preoperative, let's say low molecular weight heparins or whatever, but most of the institutions use it afterwards. a little bit depending on how long you use it, but on average somewhere between 3 and 6 weeks, what I come across. You can use pneumatic, I don't know the word in English actually, the things that you can use on the OR table to, let's say, push up blood flow, at least from the lower leg part. But especially make sure that you have something in place that speeds up your surgery, because the longer you are on an OR table, so that's not specifically only for, let's say, portal vein thrombosis, but especially for thrombosis in general, is to speed up the process. The longer your surgery takes, the longer stasis exists, and make sure it possible, let's say, to have thrombosis in general. So probably also portal vein thrombosis as well.
Yeah, excellent, excellent. So what we expect to hear is a combination of pharmacological prophylaxis and mechanical methods, exactly as you described. Quick mobilization, early discharge, but it's nowadays so common. I barely know anyone any surgeon who would not discharge early their patient or to talk against mobilization. So this is not so relevant. Yeah, and then low molecular weight heparin, you also mentioned correctly, which can be weight adjusted. There's more and more evidence coming about that direct acting oral anticoagulants, the oral anticoagulants in bariatric surgery. I mean, in some countries, they are considered as off-label indications, but this probably in the future, they will replace the injection version of heparin. Okay. That would be it. If you look at the watch, we at least talked about 20 minutes on one case, just to demonstrate the participants of this webinar, how quickly it goes on and how sharp they need to answer. So I hope we managed to demonstrate the flow of this exam, and I'm very happy to take questions at the end of today's webinar after the presentation of my colleagues.
Well, thank you so much, Daniel. Of course, I knew the case by heart, and I couldn't, of course, give all the answers straight away. I had to make you sweat a little bit as well. But as you can see, for everybody who's listening and participating, it doesn't have to be 100% correct immediately. We are looking, as Daniel said, for the way of thinking, especially. Are you thinking outside of the box a little? Can you also comment on, for example, things that you don't know, how would you get out of certain situations? So again, thank you for showing this, Daniel, because this is what it's all about. So structure your answers, think out loud. So it doesn't matter if you make sort of things that in your opinion might be mistakes. It's more about us being shown how you think. And sometimes there's many more roads leading to Rome than just one. Rapid decision making, I was a little bit slow, to be quite honest, and indeed, I always thought about the patient, as you have probably noticed. And again, this was, of course, having to do with surgery, but it wasn't directly a surgical complication. Again, if I would have come across such a case, it would have been easier for me to answer. But these kind of cases are actually in the literature that were shown by Daniel as well. If you just prepare well, you will be able to do these cases. So what I forgot to mention is that we're going to have a very nice discussion afterwards. So Simona, Philip, thank you for your question. Do keep them coming in the question box. But we're gonna let's say have a discussion based on your questions afterwards, for as long as it takes. Well, at least with a max of 6 o'clock. So thanks again for this moment, Daniel. We'll see you in a moment. So this is one of the parts, and it depends on where you are in the scheme, whether you start with cases, whether you start with literature, or whether you start with the multiple choice questions. You will hear that before you will have the exams, approximately 6 weeks before. We will send you all the schemes on where you have to be, when, etc. So just to make sure that everybody knows where to be, etc., etc. So if you are in luck and you have the same scheme, so you first met, let's say, Daniel, who's doing cases, for example, then you might drop off to the next location, which is next door to Daniel. And in this case, Dieter Birk, which I'm very happy to welcome, is going to talk us through, let's say, literature. He has a pre-recorded video that I would like our colleagues from IFSO to start. Thank you. Excellent.
Hello, my name is Dieter Birk. I have the pleasure of participating in this IFSO webinar concerning the upcoming UEMS examination. I'm a bariatric surgeon, sorry to say, but it's the truth of the first generation, started in the early 90s, still going on and having fun and getting a lot of, well, good vibes about this type of surgery. So today, I would like to share with you a few insights. I think most of you who will join this webinar are thinking about joining the exam, or maybe they're already enrolled and have a positive feedback from us, the committee. My part in this committee is being the vice chair and also in part in the examination, examining maybe your ability to evaluate and distinguish a good from a bad publication. So let me share my screen with you. So here we go. So I hope all of you are able to see this now. How to read and evaluate an article. That is, of course, an art. I'm sure most of you read lots of articles, and sometimes you have the feeling this was not really worth the time that I put into this. And sometimes I'm sure you're very happy about what you've learned and what you can now gain from your ability or your knowledge that you gain from this publication. A couple of questions that maybe you are asking yourself, and I will try to answer these questions for you during this presentation. How will the examination be conducted? What kind of publication will be presented, and how many? So how many do I have to be ready to share with the committee that will examine me? How long in advance will I be informed about this? Of course, 2 minutes at least before the examination. Oh no, just kidding. It'll be a lot more, but I'll show you or tell you a little later. And who will decide of the outcome of this examination? How will the examination be conducted? Well, it's pretty easy. We'll just sit down and talk. We'll talk about the publications that have to be evaluated in a manner between colleagues, on a friendly manner. And of course, there are going to be questions, and there's going to be presentation by you. And later on, we'll discuss what we think you did good and you did maybe not so good, and what will be the outcome of this. The oral exam, of course. What kind of publication will be presented and how many? As a matter of fact, 4 to 5 publications will be discussed. One of those will be discussed closely, focusing on the scientific value, the clinical impact, as well as the study design and some statistical analysis that has been put into this publication. The other publication that you'll be notified before the examination can be summarized in a short manner. One will be a little bit more going into detail. What kind of publication will be presented and how many? How many I just told you. I'll just give you a few examples of the publications that were discussed last year at the examination taking place in Venice. There are like keystone publications like the one from Phil Schauer that was published in New England Journal of Medicine that I'm sure most of you know, the bariatric surgery versus intensive medical therapy for diabetes. I think that is one of the major keystone publications when it comes to direct comparison between surgery and conservative treatment. So this is, of course, a publication that is worthwhile reading, of course, and knowing and discussing in a situation like this. Another one that you might have read or not, comparative effectiveness of metabolic and bariatric surgeries, network meta-analysis. Meta-analysis are always interesting to read. Sometimes they are confusing, and they're sometimes difficult to read. And it takes a little bit of going into detail and reading not only the summary to find out how good meta-analysis is. And this could be also a factor of that we look at during this examination, how good you might analyze a meta-analysis. Another one, the Ruiz-Tovar study from Spain, the prospective long-term comparative trial between OHEB, the Roux-en-Y, and sleeve gastrectomy. I'm sure lots of you people out there have read this, or maybe even have heard about it, read and heard, because this was a very controversial publication that actually had to be pulled back because there was major disagreement even among the authors about this publication. So during the examination, we also want to go into a little bit of, well, let's say, black box thinking. Hey, what's really going on in there? Is it all valid? How good is this? How can we really find out whether this is really worthwhile and true? So it's going to be multi-level discussion on a friendly manner. So let's try an example. I'm sure not many of you have read this publication. It's Bariatric Surgery by Hamish Shilton, and it was published in the Australian Journal of General Practice. Now, that is a journal that most bariatric surgeons in Europe probably won't read. But I just pulled this one out because since you've probably not read it, I just want to go through this publication together with you and kind of show what we think, or I think, is important when you analyze a paper like this. So the article is obviously directed to an audience of general practitioners in Australia. It provides a comprehensive evidence-based overview of bariatric surgery in Australia. Covers a whole lot of issues and topics that you can read yourself here on the slide. But, and that's a conclusion that we would think you would have to draw when we would talk about a paper like this, is the reach of this publication is probably limited to the target audience, as most of you probably have not read this paper. I haven't either, until I prepared this presentation for you. The key insights, however, are interesting. Bariatric surgery is the most effective long-term obesity treatment. Yes, initial weight loss is 30%, long-term maintenance stabilize around 25% at 10 years, and far exceeds lifestyle interventions and even modern medications. So this publication for general practitioner, it goes into detail when it comes to this, because it targets the audience of GPs in Australia who want to find out, hey, what's the patient, the typical or the ideal patient I send to the surgeon. It talks about obesity prevalence. 1/3 of the Australians have obesity. A lot of them severe obesity. It was updated. It was according to the updated IFSO ASMBS guidelines. The indication for surgery is really given in this publication, and consideration even for BMI below 35 if non-surgical methods fail. So it also refers to what kind of operations are being performed in Australia, pretty much the same as in Europe. It's good to know that adjustable gastric banding is nearly obsolete even in Australia. I hope Dr. Nick Dixon knows this, because he's still propagating it, at least from what I hear. The comorbidity resolution is a strong point of bariatric surgery. This paper emphasizes this and evaluates all the endpoints when it comes to comorbidity. So at the end, we want to know what you feel are the strengths of an article and the limitations, like in this one. Strength of the articles, it's evidence-based with citations from major RCTs like SleepPass, SMBOSS, Stampede. It gives clear guidelines for GPs when it comes to indication follow-up. It's balanced in comparison of the procedure and so on. And it gives practical post-op advice, which is important for a GP. It has limitations, of course. It's focused on Australian data, applicability, may vary internationally, and the limited discussion, of course, in some, especially psychological factors, is evident. And it even focuses a little bit on emerging pharmacotherapies. So this is how we would like you to evaluate an article. At the end, the strengths and limitations should be evident, and of course, your personal opinion to this. So how long in advance will I inform about these articles? The examinees will be informed about 6 weeks prior to the examination. So you have ample time to take a good look at those. Probably some of those, I'm sure you have already read anyhow. Who will decide the outcome? Well, it's us. It's the committee for the of IFSO for the UEMS exam. The board will decide after the presentation and discussion in secret. And if there are varying opinions among the board, the majority vote will decide on the outcome. So let's summarize. This part of the exam will be a dialogue between colleagues. So don't be afraid or shy. We're friends and we'll have a friendly discussion, but we want to know and find out how you read and evaluate an article. The fact that the discussed publications are disclosed in advance gives you a lot of time to be well prepared, and of course we expect you to be well prepared. The key factors for passing will be to be able to demonstrate the ability to evaluate and distinguish. Not more and not less. So that's the end of my presentation. I will hopefully see a lot of you guys in Malaga, so we can discuss this in, well, detail. Thank you very much.
So thank you so much, Dieter, for let's say preparing this. I know it's more work than you would normally think and guess. To be quite honest, the literature that we sent in last year was, well, let's say something you really should have read before you went to the exams. And I must say that all 6 candidates of last year went into extreme detail. I would advise the examinees to do it as well. And in 6 weeks, well, I must say you should be able to go into detail of every article that we send you. One thing perhaps only spoken about a little bit, it's yes, we're among friends, let's say, but we do have certain cutoff values. So you actually score a sort of points. And indeed, it's some things we really want to hear when we discuss the article. And a little hint, so if you are here today, not all articles are good. So some of them are, sometimes they have their flaws, and especially those flaws you have to look for. So sometimes you have to read a little bit further than just the article, but look it up online as well. Some of the questions coming in, great. We will start chatting away about that in a couple of minutes. And of course, all the panelists will still be here to have a very nice discussion afterwards. Next stop is actually multiple choice questions. Some of us find that harder than others. I must say, multiple choice questions were never my thing. But again, that is just part of the exam, and that is where preparation comes in. So my thanks first of all to you, Romano. for preparing a very nice video and presentation on how to, let's say, go into the multiple choice question part. So I would like to ask the committee to start the video. Thank you.
Hello everyone, and a warm welcome to this UEMS Metabolic and Bariatric Surgery section webinar. My name is Romano Schneider. I'm the section head of Bariatric and Metabolic Surgery in Basel at the University Hospital, and it's a great pleasure to be here with you today. I imagine that most of you joining us are either currently preparing for or seriously thinking about taking the UEMS examination. Having been through the process, I can tell you that it's a truly great experience, especially this time not in Venice but in Malaga, which provides a wonderful backdrop for such a significant professional milestone, and also provides the backdrop in the sense of the great IFSO EC meeting that can be also joined more or less at the same time as the exam. While the exam has several components, the multiple choice questions, or MCQs, is a major piece of the puzzle. It's often the part that causes the most anxiety, so today we're going to focus on how to master it and become an expert in navigating these questions. Let's start by looking at how the UEMS exam is actually built. It's important to understand the math behind your passing score. The examination is split into 3 parts: the MCQ section, case discussions, and a scientific paper discussion part. The point distribution is 100 points for the MCQ, 150 points for case discussion, and 50 points for the paper discussion. So totally you can get 300 potential points. There are 2 main hurdles. First, you must achieve a minimum of 50% in each individual part. Second, to pass everything, you need at least 75% of total points, which means your target is 225 out of 300. For those who want to dive deeper into the regulations, I've included the official UEMS surgery website link in here. You can find all the information about the examination also online on our homepage. When starting to prepare for this examination, the first question will be, how do I prepare? What books or what informations do I use to be perfectly prepared for this examination? So I call this the evidence-based toolkit. The most important mindset shift is that your preparation must move beyond just personal experience. So it's not about how we do things specifically in our clinic, but you must align your knowledge with global standards. So we won't ask you about things that there is no evidence about it at all, but all of the questions will be based on actual evidence-based facts. I highly suggest focusing your readings on 3 core resources: the ASMBS and IFSO guidelines, the newest one from 2022, then the ASMBS textbook of bariatric surgery by Nguyen et al., and Obesity, Bariatric and Metabolic Surgery by S. Agrawal et al. These are the gold standards the questions are typically derived from. Now let's look at the structure of the questions themselves. The first type you'll encounter is type A positive, or positive questions. In these, you simply select the single best answer from the options provided. For example, where are the leaks after laparoscopic sleeve gastrectomy more frequently located? Options include the staple line below the GE junction, near the pylorus, at the incisura angularis, or accidental perforation. A key tip for these questions: be wary of options that use absolute terms like always, never, or only. In the complex world of bariatric and metabolic surgery, these are rarely the correct answers. The second format is type A neg, where you must identify the one incorrect statement, so the negative statement. Take this example regarding BPDDS. In BPDDS, all of the following are true except you have to look for the outlier among statements about the remnant stomach, distal gastrectomy, weight loss success, and marginal ulcers. Another critical thing to watch for is the initial versus definitive trap. If a question asks for the initial step for a leak, the answer is usually resuscitation or IV fluids. If it asks for the definitive management, then you are looking for surgical drainage or a stent, for instance. Don't get those two confused. On the next slide, we want to talk about mastering the MCQ format and specifically the structure of this examination. The exam covers 100 questions across distinct clinical domains. You should expect questions from core areas like surgical technique, for instance, Roux-en-Y gastric bypass, sleeve, CDS, mechanisms of actions, side effects and complications, and endoscopy. It also covers long-term follow-up, including nutritional deficiencies, which are hard to remember sometimes, weight regain, and revisional surgery. Keep in mind the delivery is dynamic. Questions are randomly assigned from a massive validated pool. This means no two candidates will see the exact same question in the same order or at the exact same time. I brought some examples today. These are questions or multiple choice questions I took from the ASMBS textbook. So after each section of the ASMBS textbook, there are some questions that may be very similar to the questions we will ask you at the examination in Malaga. The first example is, which age, comorbid condition, and BMI is a contraindication to surgery? 56-year-old with steatohepatitis and a BMI of 41. 67-year-old with hypertension and a BMI of 36. 47-year-old with perigastric varices and a BMI of 67. Or the 19-year-old with obstructive sleep apnea and a BMI of 41. Of course, there are multiple pitfalls in this question. The first one is probably no contraindication. Steatohepatitis is very well treated with bariatric or metabolic surgery. Also, a BMI 41 fulfills the criteria according to IFSO ASMBS. The second one is a little bit more tricky. Already a little bit older person, 67, with a lower BMI of 36, but hypertension. But also that doesn't seem to be a real contraindication. Then the very young person, 19-year-old, which is also a trap that may be a contraindication for surgery, but at the end, according to guidelines, it is not. But the 47-year-old with a very high BMI, that's the trap in this question. So you think, yeah, the BMI is very high, this person definitely needs surgery. But with the perigastric varices, this is a highly dangerous case. So therefore, the correct answer is C. It wouldn't be the correct answer, for instance, if they would say this patient could undergo measurement of the portal vein pressure and preoperative undergoing a so-called TIPS procedure, which may be an option for this younger patient to treat his portal hypertension and then still undergo bariatric surgery after that. So this next slide is another example, also from the ASMBS textbook. They ask if a 45-year-old female patient presents in the clinic 6 weeks after undergoing Roux-en-Y gastric bypass with epigastric abdominal pain. Endoscopy is performed and a marginal ulcer is identified. Therapy with the proton pump inhibitor is initiated. The most appropriate next step is CT scan to rule out other pathologies that may have precipitated the ulcer. So maybe that's an anastomotic leak, for instance, some like an abscess present. That's one of the good answers, I guess. Counseling regarding cessation of alcohol use. That's probably not the first thing I would do in this patient. pH monitoring to decipher pathophysiology is also something I very rarely do in bariatric patients. Initiate H. pylori treatment due to high rate of infection. So maybe she had screening for H. pylori pre-op. If not, that's maybe an option, but maybe not the first thing I think about. Then endoscopy every 2 to 3 months to monitor for healing. That's probably the answer I would choose, because in most of the cases, as we know, the treatment with proton pump inhibitors is successful in those anastomotic ulcers. We usually say even to open the capsules of the esomeprazole, for instance, twice a day, 40 milligrams, so the healing can happen soon. And if there is really a large ulcer that may explain those symptoms, our GI department usually recommends that after 2 to 3 months to repeat the endoscopy to prove that the ulcer is gone. So finally, to the conclusions. To bring everything together, let's look at the key takeaways for your preparation at home. First, keep the math in mind. While you need that 75% overall, which is 225 points out of 300s, don't let your guard down on any single section, because you must clear that 50% hurdle in the MCQs, the cases, and the paper discussion to move forward. Second, and perhaps most importantly, think globally. It is very easy to answer based on how your department does things in your home hospital. But for the UEMS, the correct answer is the one found in the ASMBS and IFSO guidelines and the core textbooks we discussed before. If your local practice differs from the guidelines, follow the guidelines for the exam. Third, pay attention to the triggers. If the question asks for the initial management of a complication, they are looking for ABCs, resuscitation and stability. If they ask for definitive management, that is when you reach for the stent or think about revision surgery. Also, a small pro tip for the MCQs, be very wary of options containing always or never. As we know in bariatric and metabolic surgery, there are almost always exceptions. So those absolute terms are often a red flag or a trap for the incorrect distractor. Finally, remember that while this is a serious academic challenge, it is also a fantastic professional milestone. Take a breath, enjoy the atmosphere in Malaga, and trust your preparation. Thank you all for your attention today. I'm happy to take any questions, and I truly hope to see you all holding the Fellow of the European Board of Surgery diplomas very soon. Good luck to every one of you.
Thank you so much, Romano, for this very nice overview of what to do during Q&As. I would like to invite all the, let's say, board members back here, let's say, with the videos on, and when questions are asked, I will guide you towards which one should take the lead in that. Well, because we ended with the Q&A, Romano, happy to have you here. One of the questions that is asked, and do keep those questions coming, is always one answer correct, or sometimes more than one? I don't know whether you can answer that one, but otherwise I can.
Perfect. So I remember that most of the answers are a positive or a negative, as we discussed in the video. I remember back in med school we had this K prim answers where you can get like you have four different answers and you need to choose for each answer if it's correct or negative, and then you can get like half of the points or full points if you get all four correct. But I don't recall seeing those K prim in the in the examination in Venice last year.
No, no,
That's correct.
yeah. So there's always one correct answer,
Yeah,
Christine. So to specifically go into your question, but sometimes there are, let's say, two options. So let's say both are right, both are false, or
exactly.
one of them is correct, right?
Yeah.
So yeah. But otherwise, it's hard for me and the system, of course, to check, because it's a lot more work if there's more correct answer than just one, Christine. So there's always one correct answer on those all 100 questions. um, to make sure everybody gets a different multiple choice exam. So none of them are the same. The system itself generates which questions you will have based on a minimum number of the categories that Romano just showed us. So there's in total 8 categories, of which a minimum number of questions will come from. I know that you had another question, Christine, but if you, I would like you to send it in once more. I think it had to do with the literature. So, as being told by both Dieter and Romano, all the participants will get all the information, including a PDF of all the articles used prior to prepare. So if you don't have any access to either the articles or via PubMed, let's say, don't worry, you will get at least the full versions of all the articles sent to you. Are you looking a little bit forward to the exams, Romano? Because last year you were actually one of the examinees, and now you're one of the board members. How is it for you to sit on the other end of the table?
Yeah, like first of all, as I mentioned, the exam was a great experience. Of course, um, we were nervous. I like one of my very good friends and clinical colleagues who spent some time preparation and preparing the questions and the cases with me also passed the exam. That was a good thing, and also a tip that I would recommend to everyone who's taking the exams. If you have a small group, um, especially the days before the exam, it's very helpful to just have a chat with your friend and seeing how everything is going, take some nervosity. And then the day of the exam itself, it was, yeah, it's also like a long exam, right? It takes the whole day. So that's something. Of course, you have some breaks in between, but altogether, it was exhausting. But at the other side, we had almost or all the examinees, I think, passing. So a great experience at the end and a great location, and that's also one of the positive things. And good that the exam is like before the IFSO EC. So if you arrive in Malaga, then you get it done at the beginning, and then after you can uh, enjoy the trip.
Right. So I think you said it well. What I, as an examiner, saw is that friendship was actually foremost the most fun thing coming out of there, because everybody started knowing each other. So some of us already met, of course, in the past, but I think that many of you still are in contact. And I saw that Suzanne was actually online as well from last year. So no, it's good whenever you meet up again. It's something special that you went through, both of you. Okay. Well, let's go to Daniel. Is it possible, Daniel, to beside the mock exams? So you advise to do mock exams. Are there any cases available, let's say, to do these mock exams, or do the examinees have to come up with those themselves?
I think now with the plethora of online resources, if someone invests a bit of time to go to the different YouTube channels, you can find easily very interesting cases and discussions. I would recommend the SAGES and the IFSO channels, for example, but all types of other resources. Also in the handbook that we recommend, the ASMBS handbook, there are already questions after each chapter. So these multiple choice questions can also be used for preparation for the oral exam.
Right. I would give exactly the same advice. So there's so much online to be found. And of course, think about cases that you had or have seen yourself, let's say, and use those. Yeah, do agree. I'm going to Dieter. Would be good. Are you with? Yeah, there you are. Dieter, of course, being, let's say, one of the most experienced surgeons in this field, perhaps even in the world, you have multiple interests. Let's say, for example, you are very interested in also doing simultaneous, let's say, hiatal hernia repairs, etc. Is that kind of knowledge also required, let's say, during these kind of exams, or is it more the basics?
Well, I think, as you mentioned in the beginning, Edo, I mean, we're looking for the future elite in bariatric metabolic surgery, and so you have to look across the fence to the other field in order to do that. I think um, the bariatric metabolic surgery is kind of a little bit overlapping with the upper GI. So I think this is something we should at least try to cover. I mean, not in a purely expert sense, but we got to know what's going on the other playing field. So I would, of course, we concentrate on what we're doing every day, but all know that sometimes the patient has more than one problem. So we should be able to cover that.
Excellent. So to go to the last question, actually from Johnny Haddad, who's actually undergoing the exam in Malaga. He's been accredited, and actually he ticked all the boxes. So Johnny, happy to have you here today. But this question is for you as well, Dieter. For the literature review, are we allowed to bring some sort of notes on the papers? Thank you for the presentation. Looking forward to the exam. Are they allowed to take some notes from the papers with them
Well, I
during the
mean, everybody brings, I think, the publications along, and if this examinee has made some notes on the publication to remind him or herself on key points, I think that's absolutely okay. But don't bring your iPad and ChatGPT. You're not allowed to do that. So we want to know what's in your head, not what's in your appliance.
I'm fully correct. I do agree. To make sure that if you have your own printouts, that's fine. But on average, we will of course also make sure there are printouts on the table during the exam. So whenever you have forgotten that in your hotel room, don't worry. We will make sure that you will be able to do the exams. There are printed out versions there. Your other question, Johnny, is well, it's relatively optimistic question. How soon can we hold the diploma? Keep in mind that it is a lot of fun, but it is a serious exam. So with 75% of points that have to be scored on average, UEMS exams are, let's say, failed by actually 25% of attendees. Last year, the group where Romano actually was in was so good. The average score was over 80 points, which is very high. And we, as a committee, said, well, let's have them all pass. Because everybody scored over 75% of points. So let's see. But how soon can you hold the diploma? Well, we are having the exams on the Wednesday, so we will have a morning and an afternoon session. So depending on when you come in, but we need some time after you've done the exams to discuss. And also to have a good drink, Dieter, Daniel, Romano, and of course adding to that Thibaut, to make sure that we make the correct decision. Then the day after, so on the Thursday must be correct. So on the Thursday, we will let you all come in one by one to tell you whether you have passed your exam or not. And that's the nervous phase, right, Romano? That was the phase everybody was shitting their pants, let's say. But it's also to discuss whatever went right and perhaps where you should be able to walk on in terms of your knowledge. Then you will know whether you have passed. So you will go into the Congress itself with an enlightened heart, whether you have passed or not. And then the diplomas themselves will be presented to you during the general session. What's it called again? The general council session on Friday. So make sure you don't have a too early flight because normally that's in the afternoon on the Friday. We will present you as a whole team, the diplomas on stage for everybody who's in the audience. But good question, and again, very optimistic, Johnny. We'll see whether you can hold your promise to get your exam finalized and done. Going back to you, Romano, question from Anne-Sophie Studer. She asked you, what is your advice on how many times spent per question on average during the multiple choice questions, I think?
Oh, that's a hard question because probably everyone does it differently. So if you like, for instance, me personally, but I always did it like that. I go through it like once very quickly and just make some marks on those questions. I'm 100% sure they're right, or I know the answer, and just make another mark for those who I'm unable to answer. And this was also possible because it's all electronically, of course, but you can leave some notes, right? You can mark a question, you can kind of just to kind of revise it later again. And then I go through it again, like very slowly. And I know others, they just go through it once, and once they're through, they kind of send it off. I'd say like I think it's 2 hours, right, Ido? So the 2 hours are definitely enough for everyone. At least the group last year, they finished a little bit earlier than the 2 hours that were kind of the deadline to finish. So everyone needs to think of their own strategy. But yeah, like remember med school, how you did it, and then probably that's the way to go.
I do agree, and also perhaps it's good to know how the system works because you can also skip questions if you don't want to answer them at that point in time, and then you can go back to them. So you don't have to fill out everything at once, and also the ones that you filled out, you can go back to. Right? Am I correct, Romano?
Exactly. So you kind of like you had it was like an ample code, right? Like green, red, or yellow. And
Yeah.
then you kind of really see like when you put the green one, yeah, you don't need to go back, right? Because it's just like a simple answer, and you're 100% sure, so you don't even need to go back another time. And then you mark the other ones that you want to kind of think about it again, with orange, for instance. And the ones you have no clue about, you can put red. But
yeah, the system works pretty well, I must say that, and also good when we started the last time, we so everybody logs into their own account of the UEMS, and only the minute the multiple choice questions start, actually your exam is shown in the in your login part of your account. So we as examiners were a little bit nervous. We didn't understand where they were, but they only get shown if it starts, let's say at 8:30. They're only shown at 8:30, and only then you can start. So don't worry, the UEMS will make sure that works. Cool. So going to Daniel. If you really don't know the answer, let's say to a certain part of the cases, questions that you perhaps are asking, are you as examiners allowed to give hints and tips, or is it well you just fail on that part if you don't know the answer?
Yeah. So life goes on. So if you don't know the answer, I think it's good practice to say I don't know. Don't try to confabulate. Well, you can guess. You can, of course, it can work, but we can give you some hints, and then we will come together to a conclusion. We are
And
your
would it
friend,
would it
and
be
we are helping to bring you to the answer.
so that's what they want to hear, I think, with this question. And should you actually, if you say I'm gonna guess, should you tell, let's say, to the examiners that you are giving it a good guess, or should you not? Do you understand what I mean? So if you're not sure, would you say just the answer, or would you say I'm not sure, but I guess it's, let's say, this or this?
I don't have a general rule for this.
Okay, cool. Well, depends on the examiner then. Let me see. Where are the rest of the
Yeah,
questions?
I think we had a question you partially answered to
Okay.
Simona Philip. She
Mm,
asked about the anticoagulant therapy the patient had after
right.
surgery and what does if thrombophilia tests
Yeah.
were done for this patient. So I think the thrombophilia test has an influence on the long-term therapy. If these are negative, you treat the patient with full anticoagulation for 3 to 6 months, you do an imaging, and if it's negative, you can consider to stop the anticoagulation. If the thrombophilia test is positive, you have to discuss with your hematologist. You may need to continue at least a prophylactic anticoagulation or even therapeutic for forever. But this is a bit unclear. I cannot confidently answer this question.
Sure. Yeah. Okay, I'd fully agree. And again, it depends on, or this one is specifically for this case, of course. And it's more about showing the way you're thinking, but good suggestion there. I already gave it a little bit away, but there's a question about the success percentage of the last exam. That was, as mentioned, 100%. So all the examinees passed. But on average, with UEMS exams, it's 75%. If you might not make it, so if you make it, I already told you will get a diploma, etc. You will be on accredited, you will be listed, etc. So everybody knows that you became a fellow. But if you fail, perhaps for you, Daniel, what is the process then?
Well, depends in which part you failed. You will be invited to reapply. You will
That's
be
it.
prioritized for the next session to reapply. And I don't remember exactly about the fees. Probably also may get a reduction or
Yeah, so the fees are deducted, let's say, for next time. So it's cheaper to do a re-exam. And indeed, the part that well, if you failed on all three parts, of course, you have to do the whole exam again. But it depends a little bit. But we will give you an advice. But the re-exams are possible, and at least IFSO EC Congress, so once a year at least, there's an exam. So I would strongly suggest, if you would not make it, to apply for a re-exam the year thereafter.
Some people ask about the number of publications needed. As far as I know, we expect 3 publications by the applicants in the field of bariatric surgery.
Yeah, that is true. So to be quite honest, it is important to have at least 3 publications, but we had a discussion because is a video publication, for example, a publication? The answer in that case was, for example, yes. So it might be stated a little bit different on the website sometimes, but it just depends. So the minimal requirement is 3 publications.
Yeah, but if it's 3 publications with collaborative authorships along with 2,000 other people, we may be more strict.
Fully agree there. So yes, it's a point system for. So this question was about application. So it wasn't about the exam, which we're discussing right now. But when you have an application, just reach out. If you have any questions, that's the most important. You can just reach out via the website. One of us, so either me, Daniel, Dieter, Romano, or Thibaut will assess that with the whole team, and we'll come back to you whether you can apply or not. But again, the exam is for future leaders. So if you just did your first Roux-en-Y gastric bypass, perhaps it's a little bit too soon, but do then apply after, let's say, the first 50 to 100. And if you have never done any research or have never spent any time on, let's say, research or publications, then do dive into that. And again, also come back whenever you think you are ready in that term and have at least 3 publications. Did I miss any questions? Do you see any passing still by? Let me see. To know if we're in the
I think you have them all, Ido. We're done.
Great. That is very good. So as you can see, to all the viewers, of course, that we are very excited about this. We don't get any payment or whatever. So this whole board is fully here actually to make sure that we increase knowledge in terms of bariatric surgery and show the world that this is serious surgery, let's say, with serious sides to it. And we really want to make sure that a fellow of the European Board of Metabolic and let's say, and bariatric surgery is worth something. So it's a hard exam, but it actually means something. Are there any remaining questions? Do keep them coming in. I will answer them afterwards. But I would like to thank the whole board for this very nice session, I think. We're going to wrap it up. So Daniel, thank you for showing us how to, let's say, prepare the cases, think out of the box, and keep close to the patient. Dieter, thank you so much for showing us how to read literature and make sure that we will have very nice discussions during the literature reviews, during the sessions in Malaga. And Romano, perhaps one thing was not said. There will always be one of us in the room also during the Q&As, because sometimes some of the questions might be interpretable in many ways. We try to reduce that as much as possible, but there's always the chance to ask whenever you have a question about a Q&A question. But thank you so much for the nice insights, and indeed you gave away a couple of those words. Those are tricky indeed. Keep an eye out for them. There are quite a bit of people that are in this session that have already applied, as told. There are a couple of spaces left. The end of the end date of being able to subscribe has been extended to, I think, the 20th of March. So you still have around 1 month to apply. Be fast. Maximum number that is undergoing an exam is 16 this time. So hope many of you apply in the upcoming days, 2 weeks, and hope to see you very soon in Malaga. So at least at the 6th of May. Thanks again. Thank you so much, team, and we'll see each other very soon.
Thanks a lot.
Bye-bye.
Good luck for the preparations. See you soon.
Bye.